Well, welcome everyone to the 27th Degree with Chris and Nancy, brought to you by 27 Degrees Consulting. Today, we're very excited to have Dr. Carolyn Fruci with us. Dr. Fruci, who I've known for many years, is a specialist in pulmonary medicine and critical care. And we're going to talk a little bit today about a number of topics that are involve pulmonary medicine. We'll talk about the flu vaccine, myths with the flu vaccine. I'm sure we'll end up talking a bit about COVID-19. We're going to talk a little bit about lung cancer screening and what you can do to be screened if you're at high risk, and things you can do to maintain good lung health. So before we get going into all of that, Dr. Fruci, tell us a little bit about your background.
So I grew up in Massachusetts, and then fast forward to I went to Wellesley College. Then I went down south to Vanderbilt in Nashville, Tennessee, for my medical school, and then came home to Boston and did my residency at the Beth Israel Deaconess, which was a great place. Actually, I was
Great
there.
place, yeah.
I was there when it transitioned from the Deaconess and the Beth Israel to the Beth Israel Deaconess, then I went on to do my fellowship at Massachusetts General Hospital in the Brigham. They had a combined program, and that was really an amazing place to train.
I bet.
And then stayed on staff at Mass General for 4 years, and then left academic medicine and went into private practice. Initially down south, I went to South Carolina and then Virginia for 6 years, and then we came home to Massachusetts, and I've been back here now 8 years at Prima Care. When I came up here, Prima Care didn't have a pulmonary division, and they wanted to create a pulmonary and critical care division, so we put that together. We started with 2 of us, and now we have 8 practitioners, 7 doctors and a nurse practitioner. 6 of us do pulmonary critical care, both inpatient and outpatient, and then one of the docs, or 7 of us, including the nurse practitioner, and then one of the docs is primarily in the hospital doing critical care and some pulmonary medicine.
Great. Yeah, you have a great group that keeps growing, which speaks to the need of, for pulmonary, the number of pulmonary issues that are out there and the need for pulmonary medicine.
Yes, yep.
Yeah. So, well, why don't we start talking a little bit about the flu vaccine, because it is the season for that. And as a primary care specialist, there's a lot that gets thrown to me in regards to questions about flu vaccine. There's a lot of myths out there, concerns. This is particularly an important year, I would think, for people to get the flu vaccine with COVID-19 being around and heating up again. So tell us a little bit about your take on flu vaccine and, basically myths that you've heard, and maybe we can debunk some of those.
Yeah, and I can start out with a common myth.
Yeah, sure, go ahead.
I'm not getting the flu vaccine because it makes me sick every year. So go ahead, debunk that.
Yeah, so the flu vaccine doesn't make you sick. It's where maybe I should start is, the flu vaccine is against influenza, which is a virus that can really cause serious illness. And so every year they kind of look to see what strains of the flu are coming to us, and put together the vaccine. And the vaccine isn't always 100%. Sometimes it's not perfect. Even if you get the shot, you can get flu, although it can be less severe. So when you get the shot, it can make you feel a little like you have the flu. Because whenever we get sick, it's actually our immune systems that come to fight the infection, and that's what makes us feel lousy. It's actually our immune system fighting the infection can make us feel lousy. So when you get a flu shot, you can feel kind of fluish for a few days after the shot. Not everybody gets that. But to me, actually, it can be some reassurance that the shot's actually working. It will work even without those symptoms. But
I've never looked at it that way. That's a really interesting perspective. Because, sometimes when, I'm a nurse, so sometimes when, my patients will be like, no, I'm not going, I'll get sick. You're like, oh, but it's not a live virus. That's the common comeback. I haven't heard that type of, logic applied to it,
But I think the older flu vaccine, which was really a live attenuated virus, people would get very ill from at times, and that was a whole different thing. So there are patients I have come in who, they say the last time they had the flu vaccine was 25 years ago because they had the older vaccine. I can't recall when the newer type vaccine came out, but they hadn't had the newer vaccine, certainly. It's a very different scenario. If you haven't had the vaccine for many, many years because you got really sick with an older type vaccine, The new vaccine is completely different.
Yes, exactly. And that is the other thing, that the flu cannot give you, the flu vaccine cannot give you the flu because it's an inactivated, there is no live virus in it.
Right.
So it can't actually make you sick.
I think the other thing that's interesting is that a lot of people think they have the flu at times, and they probably don't have the flu. They have some other viral thing or some other respiratory tract infection. I mean, the flu can be variable, obviously, in its severity, but most people have true influenza. A lot of people get really sick with it.
Yes.
Right? I mean, I remember having it in medical school, and I was knocked out for a week. I couldn't do my rounds. I couldn't really get out of a chair for, a few days at least. So I think, that's another thing to remember. This is a potentially very severe disease. And in older people in particular, it can be really deadly.
Yes.
Do you have a sense of how many people per year succumb to the flu? I don't want to put you on the spot, but
No,
Yeah.
isn't it around like 50,000 per
Yeah, I mean,
year?
it's somewhere between, I think, I think the number I saw more recently was like 36,000. It could be and up to 50. So it's probably.
So it's quite a bit.
But it's
quite
a
a bit.
large
Yeah.
number. Yes, it's a
it's
large
a large
number.
number, right?
It's something to take seriously because I think a lot of people think they can beat it, and it's I'm not doing it. And
Yeah.
And it can cause serious illness, and that's one of the reasons. There are a lot of viruses out there that can cause flu-like illnesses or cold, like the
Right.
common cold and things like that. But the flu is one that can be very deadly, especially in people who have comorbidities. If you have asthma, if you have heart disease, kidney disease, diabetes, or some, that you can have a worse prognosis with this. But anyone, even without those comorbidities, can have a serious illness with the flu, and that's why. Even though there are other viruses out there that cause colds, because the flu is one that can cause serious illness, even in otherwise healthy individuals, that they make a vaccine for it.
Yeah.
That's why
what's the time period that the flu that you can get vaccinated? So like if someone's kind of thinking about it, then we're like running into November and maybe December, and then they're like, oh, it's too late. Like what's that point where it's too late?
really during flu season, it's never too late.
Right.
You can get the flu shot. Ideally, probably October, November, and even September is okay, but October, November is probably ideal. But the flu season lasts, really through the spring, and it's okay to get it at any time. Once you get the shot, it takes about 2 weeks to have full protection from it. So really, any time during flu season, it's okay. January, it's fine.
So then what happens, like we certainly, are seeing increase in COVID cases now too. So if someone's sick and they're thinking, gosh, is this COVID? Is it the flu? What's the differentiator there? Like, how do you know
That's
which
the hard
one you
part.
have?
It's hard. I mean, flu isn't, we don't hear about loss of sense of taste or smell with
Yeah.
the flu like we do with COVID, but really, I think if you have those symptoms this time of year, it could be either.
It's hard to differentiate.
Right, and I would suspect if you see your primary care doctor, your physician, that they will probably check you for both.
Yeah.
But that is one of the things this year, I think, why we are really encouraging people to get your flu shot this year. One, because it doesn't make it completely zero that you couldn't get the flu as well, but it will make it easier to sort of be thinking about that if you get symptoms. But also, you can get both infections.
Correct.
So you can get
Seen that.
COVID, right, and
Yeah.
flu at the same time, and both of them can cause serious
was
illness.
sick.
So getting, so that to me really is the main reason to get your flu shot this year, is because you really don't want to get both of these
Absolutely.
at once.
Exactly.
Oh
And
my
I
God.
saw a case of two of those early on in the COVID outbreak where patients had both. So, and that can be, they were young and healthy and they fortunately did fine, but in an older person, that could really be deadly.
Yes.
So now, when you practice, doctor, what types of patients are you seeing? Like, so if I'm sick and I have something brewing in my lungs, I go to Chris, who's a primary doc, and he's like, you know what, this is maybe a little bit past me. I'm going to give you a referral. So I guess it's a two-part question. At what point is Chris saying, you know what, I'm going to kind of turf this to you? Like what's that critical decision maker where a primary maybe wouldn't be able to handle some signs or symptoms and wants an expert to step in? And then part two of that question is, like, what's your patient base look like? Is it mostly people with lung cancer? Is it mostly people with asthma, pneumonia cases? What what type of patients are you seeing the most?
Yeah, so for the first part of the question, really, it's variable because we do see a number of different types of illnesses with lung disease, and it can depend on the physician's comfort level. So some physicians feel very comfortable managing, like asthma and COPD, but we are here we're here to help at any level of comfort.
Sure.
Some people, if they have a diagnosis of COPD, we see them. But certainly if they are still having significant symptoms despite the medications that they're getting, that would sort of be, a definite indication. People who have shortness of breath and they can't be figured out why. There's a number of different things that can cause shortness of breath, or if they have a lot of other comorbidities, sometimes that would lead, and sometimes it can be difficult to tease out when people are symptomatic, which of their, illnesses or comorbidities is causing the problem.
I mean, I can tell you what I do, Nancy,
Yeah,
if you're interested. So.
Yeah, I am, because as a doctor, when are you like, oh, this isn't my wheelhouse?
Yeah, I mean, we see a lot of patients who have pneumonia, asthma, COPD, and in general, we feel comfortable with that. I do at least, and I think most primary care docs do. But there gets to a point you've started the usual meds for their COPD or their asthma, and they're not responding. Then I send them over to pulmonary. Anyone who's on oxygen, they need to be followed by a pulmonologist. I think pulmonary nodules, I'd like to have the pulmonologist follow because there's always that risk that something will be lost, and they have a whole system in place to follow this. So if the patient doesn't follow for their CAT scan, they're going to get a call, they're going to be, notified. A lot of primary care docs may not have that in place to that level. So I think it's a good safeguard. Patients with lung cancer certainly end up following with a pulmonologist. There's a host of, oddball diseases, sarcoidosis, things like that. They all follow with a pulmonologist. And then I send a lot of patients to the pulmonologist who have shortness of breath that I can't sort out.
Right.
So someone comes in, they're short of breath. I do the usual workup, and it's negative. Maybe I've explored a cardiac cause. I'm wondering if they have heart failure or coronary artery disease, and I looked at that and it's negative. I really can't sort it out. I'll send them to a pulmonologist also.
And cough, that's another one.
Cough's a big one too.
Yeah.
Cough's a big one. That's one we often send. There's like some common things we see with cough: postnasal drip, asthma, acid reflux. But once you explore that and treat those things, and you can't figure it out, a pulmonologist can be really helpful.
And so Chris kind of covered it, but the second part of that question is. Right, so we see a number of different things. I would say we see a lot of COPD, or the chronic obstructive lung disease that people get from smoking, and we definitely see a lot of asthma, lung nodules. We see a lot of, and I agree it is important because there's different pathways in terms of management of the nodules.
Sure.
And sometimes even just giving patients reassurance, is important that it isn't. That it most likely is a benign or not a cancer.
Right.
Not a cancer.
Right.
Yeah, many are. Most are probably. So.
Right.
And we see a lot of the cough. So we talked about that. Cough, shortness of breath, COPD, asthma. People have the lung diseases like scarring in the lung, like what's
fibrosis.
Called pulmonary fibrosis. Pulmonary hypertension is another one, which is where you have higher pressures in the blood vessels in the lungs, as opposed to just the regular hypertension that we hear about. It's high pressures in just those blood vessels, and there are definitely kind of specific therapies and treatments that we have for that, that we can help with.
And then there's a whole critical care aspect of it. I mean, you are the guys who run the ICUs. Yes. I mean, in our area, cardiologists are involved in the cardiac aspect of a cardiac ICU, but the medical ICU, where patients come in with respiratory failure and it's run by pulmonologists. So that's a whole other area.
Yeah.
So now when Chris is talking about the ICU, I think most people know that's the intensive care unit inside the hospitals.
Yes.
Yep. So you see those sick patients.
Yes, we do. Yep. So our group, we run the group at Prima Care. We run the ICU at St. Anne's.
Yep.
And we see there kind of everything too, from just bad. We see people with bad pneumonia, flu, who end up very sick. And all kinds of different illnesses. Sepsis. People have heard about sepsis. Yeah. Sepsis is where you get an infection, and that kind of response to that infection spreads throughout your body and causes significant severe illness.
Yeah. Well, maybe we could talk a little bit, since we kind of talked about all the things that you do as a pulmonologist, we could talk about the lung cancer screening, because that can
Yes.
really be life-saving to many patients.
Yes.
And I don't know if everyone out there knows that we have really good lung cancer screening now.
Yes, we do. We have a very robust program at Prima Care. And so lung cancer screening, it's different from other screenings that we have, because it's a targeted group that we look at rather than a population-based. So like for your breast cancer and colon cancer, the screening is like, everybody over 50 or needs to get screened. For lung cancer, it's a targeted population. So it's specifically people who have a significant tobacco history. So you're not just screening everybody who's over 55. You're screening people who are, I think, between the ages of 55 and it's like 77 to 80, who have a 30-pack-year smoking history and are either actively smoking or quit within the past 15 years.
Describe what a 30-pack year
Yeah.
history
Coming back
is,
to that,
because, yeah.
Yes. So a 30-pack-year smoking history means that you have smoked the equivalent of a pack a day for 30 years.
Right.
So that would be like 2 packs a day for 15 years, or half a pack a day for 60 years, or 1 pack a day for 30 years.
Right.
So in that, like some of the fake non-smokers, like my husband, my husband checks off the. Ooh, I shouldn't say this on air. Sorry, John. But say hypothetically, my husband is checking off the non-smoker box, but hey, he goes golfing. He has cigars.
Right.
He'll go out in the yard. He'll have a cigar. I mean, my brother chews tobacco. Oh, here I go again. Someone I know that's close to me chews tobacco. Like, is that considered like a smoking
They have
history?
other risks that they're at risk for.
So chewing tobacco, I think, is more associated with upper airway cancers, like ear, nose, and throat cancer. Sorry, this thing keeps falling on me. And cigars, that's hard to quantitate.
Yeah.
And so we typically don't sort of, if someone's having a cigar here and there, we wouldn't. It's hard to quantitate as to the smoking history. So we don't necessarily really always screen those people. That may be in the future. There may be data to support that, but right now it really is.
We really focused on the cigarettes.
The cigarettes, the cigarettes.
So what about pot smokers?
I know. So, and again, the numbers in terms of the risk, there probably is an increased risk for lung cancer with smoking everything into your lungs. And but again, we don't have the data there to support screening for lung cancer in people who use marijuana.
Because this data is they're based on controlled studies, and
so
I don't know if there'll ever be a study on marijuana and
so there's no
lung
like
cancer.
equivalent.
I don't know that that's going to happen, but.
It may with the legalization and
Maybe.
having it more common. It may come that we have, there's an ability to do a study like that.
Yeah.
But for this, this was a study. I think the study was done in the early 2000s, the National Lung Screening Trial. It compared chest CTs, CAT scans, or low dose of radiation, about the same as you get with a mammogram.
Yeah, so that's an important point.
Yes.
It's low radiation
Yes.
dosing.
So a CAT scan at low dose with a low dose of radiation compared to a chest X-ray, and looking at the ability to detect lung cancers early, at a stage where they can be cured. And they did find that I think with that, comparing it, that doing CAT scans versus chest X-rays in people with those risk factors, the 55 to 77, 30-pack year smoking history, and either actively smoking or having quit within the past 15 years, that you could reduce mortality by 15 to 20%. Basically, for every 1,000 scans that you do, you save about 3 lives. So that's that's pretty powerful. That's actually as good as, if not better than, the screenings that we do for mammograms and colon cancer.
Yeah, that's great.
How does family history factor in there?
So family history is important. It doesn't factor into who we screen, but I think as as a physician, I think we definitely might be more prone to check, that if someone who has a significant smoking history maybe doesn't quite meet criteria, that's a kind of individual thing that you would decide, with your physician. We don't do the screening CTs on them, though. They don't fit we are pretty strict because of the data and the regulations around the screening, that people have to fit the criteria that we talked about to get screened. But as a physician, you might decide on the patient with a significant family history of lung cancer and multiple family members that you were going to do a scan of some sort to check someone. But we don't, but they don't fit the criteria for the screening.
So this might be a real simple
change.
question, and I'm sorry for this, but
That's okay.
so is lung cancer more causal? So if like a lot of people in my family, if I'm not a smoker, are my chances of getting lung cancer like really diminished?
Yes.
Is it's caused by a certain?
Yes. So, I mean, there is some data that secondary tobacco exposure can increase your risk of getting cancer, lung cancer. If you live in a home or a space where people are smoking, there's definitely a potential for increased risk for lung cancer and other smoking-related lung diseases or just diseases. But in general, if you are not a smoker, your chances of getting lung cancer are low. They're not zero. Some people, we do definitely see people who do not smoke and don't have significant exposures that can get lung cancer.
It's rare.
Right.
But we see it.
Yeah. But not, but yeah. So.
You know, it surprised me because when I was just doing a little research for this podcast, I had come across a stat that lung cancer is a second, it causes the second most deaths of all the cancers.
Yeah, no, it's a highly, it's still.
I just thought like in general, like the smoking rates were going down. So I think that stat surprised me that it caused so many deaths.
Yeah, I mean, and that may, if we continue to be good about less smoking, that may go down, but the risk is there. I'm trying to think of the way to describe it.
Is that because it's picked up like late, like it's not early detection?
Yes, so
that's the problem.
Yes, so as I say, there's like a lag behind the decreased smoking rates
that would
and
make
the cancers.
sense, I guess.
And the lungs are actually interesting. The lung tissue, we really don't have pain receptors in our lungs. The lining of the lung has pain receptors, except when you get pleurisy. But sorry, I need to fix my mask. I need a smaller mask. The lining of the lung has pain receptors, but the tissue does not. And so cancers can start and grow and get pretty big before someone has symptoms. And that's one of the reasons I think that we really had looked for and thankfully found, a way to screen for lung cancer, because by the time often we discover lung cancers, they're far advanced because of that issue. So.
So is screening automatic? Like you were saying before, like for colon cancer, when someone hits 50, you're scheduling as a primary.
It has to be recommended by the physician. So, and the physician actually, like at Prima Care, we go through a checklist of things to make sure that they meet the criteria, and basically so that it'll be a covered service for the patient. But you have to be thinking about it. I mean, if the doc's not thinking about it and the patient doesn't ask, it's not going to get done. It's interesting. I mean, I think that everyone thinks about mammograms. Everyone thinks about pap smears. Colonoscopy is on everyone's brain. This is coming around. It's as important, and we need to, as physicians, think about it more. I think a lot of us are now. Right. But patients need to be educated too, because they need to ask their physician about it, because it may not be brought up as someone would bring up mammograms or colonoscopies.
Right.
Yes. So yeah, we are trying, we definitely want to try to get this on people's brains, because it is a conversation that should be had, and it is kind of a discussion between a physician and a patient about, the screening, and really for any screening process, I'm sorry about my mask, for any screening process, you want to have that discussion with cancer, because, screening should, if a patient is otherwise healthy and would absolutely want treatment, I think, and is in that risk group, I think the risks, the benefits outweigh the risks.
Absolutely.
But still, people may, if someone's got a lot of comorbidities, like really bad heart disease or kidney disease or liver disease or some combination of those, and maybe they wouldn't tolerate treatment or not want treatment, then they shouldn't get screened, because if you're not going to treat it, then
because that's no logical next step.
Same thing with the other screening tests too.
Yes, same as any screening test. So that discussion should happen about the risk. There is some radiation exposure. It is lower, but it's there. So some people, you'd want to talk about that with people, and also the treatment that by the age of 55, which is when we would start screening. And sorry, I'm trying to find a way to fix my mask here so it won't keep falling down. But by the age of 55, we've all been breathing on this earth for a long time. Right. So we can, most scans show something, a little bit of something, or, like little tiny ditzels or things like that. So But over 90% of the time, I think it's like 95 to 97% of the time, even in this high-risk population, those are nothing. So there's this potential for false positive scans, which can cause anxiety and can sometimes lead to additional testing, on lesions or findings that turn out to be benign.
That's why it has to be a conversation.
Yes.
I mean, if someone tells you, look, I wouldn't have anything done if I knew about it anyway, or they're so ill that they couldn't really have anything done, why do the scan? The chances are you might find a little something, maybe you won't, but if you do, you're going to make them nervous. It's going to raise the level of anxiety needlessly.
Right.
So smoking, big bad habit, with particularly this disease. What's the conversations like with you and your patients with trying to stop smoking? I mean, is it still 7 to 8 quit attempts that people are struggling with? And there's some drugs out on the market. Is there a wonder drug out there that works well?
Yeah, and absolutely, and as part of any kind of caring of a patient, but particularly in the setting of having a discussion about the lung cancer screening, in patients who are continuing to smoke, absolutely, we need to have that discussion with them about the importance of quitting smoking, both for decreasing the risk of lung cancer, but also, the COPD or the lung disease, and also, put you at risk for other illnesses, other cancers, colon cancer, heart disease. I mean, it doesn't stick with just the lungs. Smoking will get everything.
Vascular disease.
Yes.
It's really terrible.
Yeah.
I mean, it just causes multi-system disease, not just the lungs.
Yes,
So
yes.
we just see a lot of issues that patients have.
And but it is, in terms of it is the one thing we have that can decrease your risk of getting cancer is to quit smoking, and also to get for lung disease, to prevent decline in lung function. The one thing that will do that is quitting smoking. So it is an incredibly important conversation to have. And as you alluded to, that that it can take multiple attempts, and that's why I tell people that all the time. That, if you keep trying, it will. So don't get discouraged if you try and it doesn't work out the first time or the second time. Keep trying, because it will eventually work if you stay at it and really want to do it. There are medications out there now that can absolutely help, and the data does show that the chances of you staying off cigarettes or quitting is higher. People can do it without any medications, but that there is a higher rate of success with using one of these medications. Chantix is, I guess, is the one you see on the news, varenicline. Does really help. It's that Chantix is a partial nicotine receptor agonist. I don't want to get too far, but it kind of binds to the nicotine receptor, stimulates it a little bit, so you get a little bit of that satisfaction from the nicotine, but also stays bound, so that if you smoke, you don't get as much satisfaction of it, because the nicotine from the cigarette can't bind to the receptor. So it can work really well. Some people have pretty significant side effects from it in terms of nightmares, but most people don't. Most people tolerate Chantix just fine, and it is probably the best one out there in terms of medications. I think there was actually just some new guidelines that are published or will be published about that. That is the kind of gold standard agent to use if you can. There's also nicotine patches, which can work quite well, nicotine gum, and lozenges, and bupropion or Wellbutrin, that you can use that in combination with the nicotine supplements, and that can also work quite well.
And I don't know if you've had this experience. I've had some patients who've tried multiple times and they just really have been unsuccessful. But those patients, some of them, they've been able to stay on Chantix and at least cut down their smoking to a lower level. So maybe they were smoking 2 packs a day, and now they're smoking a half a pack. That certainly would reduce their lung cancer risk and their risk of COPD and other diseases associated with smoking.
Yeah, I think if it can cut it down, I think right now I don't know. I think that is probably okay. I don't think we have the long-term data as to in terms of the safety of that, but it is. To me, it is better if it cuts. If you can cut back and smoke less, that it is most likely fine, and then we will. The time will tell in terms of any potential side effects. But I think that if it makes you smoke less, that's good. The one thing, I'm so sorry about my mask. I'm like, I lost my train of thought there. But I was gonna. That could be a topic for a whole nother thing. But the vaping is not. You don't know the safety about vaping. There's no data to suggest that it can help you quit. I mean, they haven't, and there's no data to suggest that it's safe.
Right.
It may be safer than smoking with respect to some things like COPD or cancer. I don't know. We don't know. But we don't have long-term safety data on it in terms of the lungs or other organs. The nicotine doses from puff to puff, there's no regulation. You can get really high doses of nicotine. And the flavoring of these things is just a tragic with respect to our use.
Oh, yeah.
That these flavored vaping things are out there. It's addicting a whole new generation. So,
Sure.
Now in
I got
Mass,
it,
we
yeah.
just outlaw the flavored.
in Massachusetts, that's
Yeah, I guess.
here in Fall River, we're right next to Rhode Island, where you can go by the flavored.
But I've
Yeah.
had a number of patients who switched over to that with their thought process that they would get off nicotine,
Right.
and now they're just addicted to another product, and who knows, like you say, the safety of that product down
Right.
the road. So
We do know it can cause inflammation in the lungs.
Sure.
Can absolutely cause
Oh, yeah.
inflammation in the lungs, and in the flavorings, most of them are meant to be ingested, not inhaled into your lungs.
Yeah.
And so the toxicity of that, I think, we definitely will probably
Horrible.
see some problems from it down the line. So it's just, and I have people that come in who have switched to vaping from smoking, and some of them say they can't do it because it makes them cough, but some of them say, that they feel much better. Some patients do report that they feel much better. So, my encouragement to them is that if you have done this, you have to do it with that guise of that you are going to wean yourself off.
Right.
Sure.
It can't be just something that you're doing instead of smoking. It has to
Right.
be with a goal of coming off that as well, so off the vaping.
I guess the Mayo Clinic just had a publication out too saying when you're looking at trying to quit smoking, that if you're, oh my God, you have a problem with your mask, my throat's getting all junky. But if you're trying to quit, it's effective to pick a day and just try to really go to zero on that day. And I thought that was kind of interesting. They even had kind of guidelines with that, like it should be within the month. And they found that has shown a higher success with that actually being able to quit. And I thought it was kind of interesting with the timing because we have the Great American Smokeout next month. So I think it's November 20th, around the 20th, right? So I thought, if anyone's listening and they're thinking, maybe I should quit, it's right around the corner.
good time to do it.
Right around the
Good time
corner.
to do it. Yes, and I think it does help to sort of have a plan to sort of kind of get yourself psyched up that, okay, on, that this date, 2 weeks from now, on that Monday or whatever, that I'm going to try to quit. And I tell people that all the time, that, if you're trying to quit, and you pick your date and you're not, you quit and then you relapse or fail, it's just, that's all right, take a breath and just pick another date.
Right.
When you're going
That's
to try
it,
again. Pick another date.
Absolutely.
And there are other things that you can do. There's a lot of good information online about, with tips to help you quit smoking. But some of the common things that I tell patients in terms of quitting smoking are to make a list, especially these days when we're at home a lot with COVID. Make a list of like 5 to 10 things that you can do, even if it's like rearranging a bookshelf in your house that doesn't need to be rearranged. And put it on your fridge, and when you're get that strong urge to smoke, just pick number 4 and go do it for 5 minutes. Because often, if you distract yourself for just a few minutes, you can overcome that urge.
Yeah, and they're good resources, like you say, on the internet. I think QuitWorks is one.
Yes.
That's
QuitWorks,
very
yes.
useful that I recommend to my patients. So, I mean, and I it's interesting. I think patients don't realize they think about smoking with lung cancer and maybe COPD, but they don't realize all the other disease that it causes:
Yes.
heart disease, vascular disease, other cancers, bladder cancer. So there's just a lot of bad stuff that it does. So
It's just like I said, it doesn't. It's what I want to say. It doesn't discriminate based on the organ system. It
No.
goes after all of them.
So the other thing with lung cancer, am I worrying about radon exposure? Like, do we have these conversations, or is that something where it's like,
we don't. I don't a lot have conversations about radon with patients, and that may be something we should do. But
well, I'm reading and I'm like, I don't know if I should go out and run out and buy a radon test kit or something from my house. Like, they make you nervous when you start reading stuff. But is that, I know we're not like a high, I even looked at my zones in Massachusetts. I'm like, I guess we're not like a super high zone.
Yeah,
We're
and I'm
like a
saying
moderate
it's
zone.
We're on a
it's not
lot of
something-
ledge, you know.
yeah.
That's
Yeah.
the issue.
So it's not something that we see a lot here, so it's not something that
Okay.
I think there is definitely some data out there that there is some association there, but it's nothing like what we see.
So I don't have to
from
run out and go
cigarettes.
order a test today, right now.
I'd quit the cigarettes first,
Yes,
Nancy.
yes, it's fine.
Damn. All right. So can we talk a little bit too about the changes that you've seen? So you said you've been at Prima Care for 8 years. So over the past 8 years, like, has there been any big breakthroughs with lung cancer? Are you getting excited about anything? Is there research around the corner that you're like, ooh, this is going to be really good?
So, and I'm not going to know the names off the top of my head of all these, but we definitely in the past, over the past 8 years even, have started to see some progress in the treatment of lung cancer. Now when we get biopsies and stuff, we always make sure to get enough tissue so that they can do testing for these, there are certain proteins that are in the cancers that if they're there, we can do targeted therapy.
Yeah.
To treat the cancers, and it's a lot less
Immunotherapy.
toxic. Yeah, the immunotherapy a lot less toxic than what we have had in the past. And then there are these new things, the PD-1 and PD-L1 inhibitors. I apologize if I got that wrong, but they're immune checkpoint medications that they're really interesting. They go in and they kind of allow your immune system to see the tumor. Like they're a checkpoint inhibitor, so they go in and they basically, kind of wake up the immune system to the fact that the tumor is there.
Yeah, that's a great way to describe it.
Yeah.
That's great.
And so the immune system can basically keep the tumor in check. And they do have some side effects at times, but for the most part they're very well tolerated, and they really have changed the mortality with lung cancer significantly. They don't work for everyone, but where they work, it's been very impressive for people with late stage cancers are surviving a lot longer. So that's been
great
really,
to know.
it's been.
Yeah, I think that's an exciting point.
Yeah,
I think this
really
is,
exciting,
we don't want to get too far afield, but I think as far as just cancer therapy in general, these immunotherapies that are targeted based on the particular person and even, genetically devised therapies. I mean, that's going to be the wave of the future. I mean, with chemotherapy, you're giving a poison that basically not only kills the tumor, but affects the rest of your tissue in your system. But these targeted therapies are fascinating because they can really be directed right at that tumor more specifically.
So that's been it's been really, it's been amazing, and I think there's more to come with that. I think now that they kind of know that this type of thing works, I think we're going to see probably more of it coming, and hopefully to help all patients, with cancers, not just lung cancer but other cancers, and they do work in other cancers, but I think it's a revolution that we're going to be seeing in that. I really do.
I think so too. I think 25 years from now, physicians and healthcare providers will look back and say, I can't believe they gave, this chemotherapy or whatever. It's just like you think about hypertension. I mean, we have dozens of therapies now, but you think back to the 1940s, what did we have available? A couple meds. It's just fascinating how things have changed so quickly in medicine.
Yep.
So then, as kind of a recap, we're looking at definitely promoting the flu shot, and
Yes,
it's
get
so
your flu shot.
widely available at your pharmacies, at your doctor's offices. So that's a big important point.
Especially this year
Yeah,
with
especially
COVID-19
this year.
You do
for
not
many
want those.
reasons.
Yes.
Right. And then looking, if you are a smoker, and looking at your chances of getting lung cancer, there are screenings available out there if you fall into a certain group.
And really life-saving,
Yeah.
screenings. And we should look at this the same way we look at mammograms and colonoscopy and that. And we're doing this right in Fall River. We're doing it at Prima Care. So
we do it. And
it's really important to
one thing I
think
didn't
about
say-
this.
One thing I didn't say earlier that I did want to say about the program is, it is a program. So, once you're in it, we make sure that we follow up the results. We make sure that, that people who get screened are aware of those results, as well as and their primary care doctors are
That's so
aware.
nice,
and
'cause
that they have
sometimes
appropriate
it's-
follow-up.
Yeah.
Yeah, because sometimes it's so difficult to navigate
Yeah.
the healthcare,
Right.
the whole healthcare process. And you're already nervous and you're anxious. So now if you're in a comprehensive program, like everything's getting ticked
Right.
off.
We're doing everything so that people get the right care and things don't get missed. Yeah.
And that's crucial.
Now, patients, if they go in and see their doctors, they can request to have a referral to your group as well.
Yes,
Okay, perfect.
absolutely. So,
And that's great. All right. Is there anything you want to send out as a summary message to all the listeners out there? One last thing, other than quit smoking?
well, no, in addition to.
In addition to, yes.
So yeah, just it really is important this year. I mean, it's always important, but this year to get your flu shot. You really don't. Both of these viruses are going to be out there, and you really don't want to get both. So, to the extent that you can prevent that, get your flu shot and follow all the other precautions. Social distancing, wear your mask, and lots of hand washing and saying, just be smart and be safe about that. That smoking cessation is possible. It can be hard, but it's possible. Just keep trying and, talk with your physicians about it, because we have a lot to offer to help. And what else? The final thing. And the lung cancer screening. Right? So the lung cancer screening, we have a really robust program at Prima Care, and it's absolutely talk to your physicians about it. If you meet those risk factors, you should be having this conversation with your doctor to find out if it's the right thing for you.
Perfect.
Great. Excellent.
Thank you so much.
Yeah, thank you. This was wonderful. It was a great conversation. I think we all learned a lot. We really appreciate you taking the time out to do this. Thank you so much. And for everyone
for
out
having
there,
me.
this was our pleasure. Thank you. And this is the first of a 3-part series, a medical series. And the next talk we'll have, which will be in 2 weeks, will be GI oriented. We're going to talk a lot about probably colon cancer screening on that one. And then the one after that will be a cardiology topic. And there's been some really amazing advances in cardiology.
Yes.
So we have a cardiologist who's going to come and talk about that. And in some things that I'm sure many of our listeners aren't aware exist. So very
That'd be
good.
awesome.
Well, thank you, everyone.
Thank you.
And once again, shout out to a couple, Taylor, our assistant here, who's behind the scenes and never really gets seen, but she's there. I wanted to do a shout out to Taylor. And also Eric B. Media, who, if you're interested in podcasts, Eric is the guy to do this. It's right here in Fall River, and you can contact him at ericbmedia.com.
All right. Thank you.
Thank you.